So it's clear to me I'm going to be the low production value talk in this session. I have some handouts with problems coming around, or I think we can just pass them around. Okay, so I'm Dahlia Remler. I'm sort of in the wrong session. I spend my career teaching professional master's students, not economics students. But this is essentially a health economics course. It used to be called that. It's healthcare costs and financing now. What's coming around and what I'm going to spend most of my time on are a number of applications, in-class exercises, or assignment or exam questions. I'd be really excited and happy if people actually use them. My one request is actual attribution. I feel like in teaching we forget our other academic hat we do with our students in our research. Okay, so the title of my talk is focus on the actuarially fair premium. And so my position is that in a health economics course or a similar course, that should be the main organizing concept. Why do I think that? Hopefully you'll believe me after you see what I have. I think everyone in the room probably would agree, particularly in an American context, but really I think more broadly. It's the key to key policy issues and even private sector business perspective. A lot of my students work for hospitals, insurers, other practitioner groups, advocacy organizations, government organizations, and the composition of the risk pool via and essentially the actuarially fair premium is the key to understanding debates about risk pools, why the Obamacare premiums are they are, Ted Cruz's latest proposal. It's also the key to cost of care drivers. Why is healthcare so not affordable to anyone who's not rich? What drove cost growth? The other reason I like to focus on this is I can make the course have not high entry barriers. A lot of professional master's students, I currently teach Masters of Public Administration, I've taught a number of different ones, are not the most quantitative students. You have to really ration your equations very carefully. This works, and all of the content I'm teaching today, although not all the content in the course, requires no economics background at all. So this course also works if you want an economics course for undergrads, maybe who are pre-med. I've taught a number of clinicians in a lot of context and so on. So what's the basic conceptual structure? So as everyone in the room probably knows, the actuarially fair premium are the expected costs, ex-ante costs of care provided for a specific pool of uninsured, a specific risks. And when I teach the course, I start out by teaching the idea of the value of insurance in a fairly John Nyman kind of perspective. So when I start out teaching it, everyone has fixed risk, such and such percentage of each disease, and there's no ambiguity about the care people would get if a certain condition arrived. And then I say, what are the costs and benefits to you if you have insurance versus if you don't? Today, I've put a little bit of that in the moral hazard cost containment, but today I'm going to focus primarily on selection material. Focusing on the risk pool composition, I think that's the most important material. So we keep the expected care constant. That's not the focus here. We're just focusing on what drives the risk pool composition. I'm going to spend less time taking you through, but you do have one example of how I use the same type of model I use for value of insurance with moral hazard or cost containment. So I'm focusing on choice of care and drivers of care. So for that, I keep the risk pool constant. In fact, I just keep it uniform. We have one group of people, they're all the same initially. And then I'm focusing on, what drives care choice. Okay, so the first exercise I'm going to show you that I'll take you through carefully, and so you should all write your answers, and I'm probably going to write on the board. I said I was low tech, low production values. This is something I would do in class. So I've gone through my notes, I've given the definition, an AFP, you sum over the different risk groups in the population, you multiply the share of the population times their expected cost. So I teach that. Then I have a really simple example, 95% low risk, 5% high risk, here are their expected costs. I used to jump directly to the AFP for this population. Then later it turned out that if I asked for what's the actuarially fair premium for a plan with only low risk people might say, some of the students might say 5% of $500. So I get them early in class. I do these 5 questions as either a small group exercise, or I literally just stop class and ask everyone to do it individually right then and there. So what's the AFP for an insurance plan with only low-risk people? $500. What's the AFP for an insurance plan with only high-risk people? $30,000. I cover this material after I've already taught the empirical material about how concentrated health care costs are, as well as having taught them about the empirical evidence about persistence. So they have some sense about of just how different low and high risk people would be. So then, as part of this exercise, what's the AFP for an insurance plan covering the entire population? Of course, it's 0.95 times $500 plus 0.05 times $30,000. So again, you can see students do need to learn to think a little bit analytically. They do need to be a bit quantitative, but no prior experience necessary here at all. What is the AFP for an insurance plan covering a represented sample of the entire population? Identical. What is the AFP for a plan with disproportionately greater share of high-risk people, specifically 50% higher risk? Oops, already broken the chalk. And with that, we have the tools to look at a wide variety of selection applications. Ensure strategies to gain positive selection by marketing free gym memberships, a wide variety of lemon dumping and cherry picking schemes, community rating, what was the impact of grandfathered and grandmothered plans under the Obamacare effect, and so on. And we can do some with the toy models so that students get used to working with the actual numbers, and then also talk more generally and intuitively. Then we move on to solutions, such as risk adjustment. So what I would do is, this might be on a different day of class, or it might be on the same day of class, but I will continue the same exercise. So I remind them of what we already did, and I say with the same population and ignoring administrative cost loading, which we'll talk about a little at this point, but we're going to spend more time on later. And I emphasize, what do plans have to receive in total, whether how much of this is coming from the policy buyer, from a government agency, from a quasi-independent agency, whatever, in order for the plans to be willing to provide, or to sell, sorry, for the typo, a policy with for a high-risk person. Making the point is, they won't want to get rid of sick people if they're getting enough money. And so the answer is their expected costs that they're going to pay out for care are $30,000. They need to get $30,000 plus, of course, the loading costs in order for them to be happy. What do they need to receive for a low-risk person in order to be quite happy, but not to be spending all of their time and energy to cherry pick such people? You know, if they're getting $15,000 or $5,000 for people whose projected costs are $500, that's really profitable. They're going to be putting all of their efforts into doing that. And so, you know, I talk about, so would a nonprofit who has all sorts of wonderful public interest things to do with that money. Okay, so that's the key. We emphasize that. And then we talk about the mechanics. So I've deliberately set this up not to emphasize the mechanics. The students Masters of Public Administration students I have are focused on a lot of management and budgeting issues and implementation, and all of that's great and important, but it's not what I teach them. So I want them to get the sort of big picture principles of what to work, but now we somewhat move on to the structure. So I say, okay, what do we want out of this? In this one, our goal is for everyone to pay the same premium out of pocket, regardless of risk. The plans to have no incentives to lemon dump or cherry pick. And the scheme, in this case, to be budget neutral without outside subsidies. And you know, later we can talk about adding those. So I ask, how are you going to implement this? What are you going to charge the individual people? What are you going to pay the plans? What would you need to do? All right, so that is the last thing I'm going to go over carefully. I have an example here of you know, something that's no longer your first in-class exercise. And parts of these toy models have right answers. Some parts of them have only right answers. Some of them I don't want to put too much structure on to get them to think. So for example, I tell them that per capita income is $50,000 per year. The expected medical costs of an aged patient are $100,000 a year. So in Part A, where the insurers can identify and are permitted to exclude people, and they're going to want to have two plans, a high-risk and a low-risk plan, some students will say no one can afford $100,000 per year. Others will say very few can afford it. I haven't set it up. So I want them to sort of start, even with the toy models, thinking a little more realistically. Okay, so those are the kinds of things I do with selection. I'm now flipping the assumption. So now we're not worrying about the composition of the risk pool. We're worried about what drives care. So I have a model where everybody is the same initially, same ex-ante risk. And there are these three artificial periods, and we talk about how this doesn't relate to the real world where uncertainty actually unfolds over time, but that this is just to give them the key ideas here. So I have only three periods in this model. Ex ante, when there's uncertainty, where you make your plan purchase decisions and you enjoy consumption of non-health stuff. Then the uncertainty is resolved, then you enjoy your resulting health, and in the kind of ambiguity, you're kind of still enjoying your consumption of non-health stuff. So now, the percentages are not the share of the population. We have a uniform population. And it's just your probability of ending up in a particular state. How am I doing? Okay. So, you know, we have a 1% chance that the person is going to cost $250,000 if they get kidney disease, a 4% chance that they'll cost $100,000 if they have a heart attack, and a 95% chance they're going to end up in good health, and it only costs $1,000. Okay? So again, as before, I'm emphasizing that to my students, these add up to 100%. We have to know everything that can happen to people, and if they're going to cost zero, then we have 95% times zero. So again, this is sort of the John Nyman perspective. So what I gave you in the handout, parts A through D are what the kind of thing I would have done with value of insurance. I would have started with a one disease model. I would emphasize the part about pure affordability, but also show other versions with financial protection, which is what you see in D, in Part D. So I don't need indifference curves. I don't need risk aversion. I can do it again. It's low entry barrier. You're training the students to think analytically and quantitatively, but it's low entry barrier. Okay, and then with this, I would teach the idea of incremental costs and incremental benefits. So here I am, before I know what's going to happen to me in health status. Do I want to buy a health plan that costs me the actuarially fair premium? And if I do, in the simplest model, you're fully insured for everything. Or do I want to go without and take my chances and depending on what my lifetime wealth is, maybe not be able to get any treatment for kidney disease? I haven't shown it to you either there or in this, but I would talk about in more advanced models, if I have kidney disease and I get treated, what happens to my health? If I don't get treated, what happens to my health? Getting in the similar types of things people do in a cost-benefit or cost-effectiveness analysis. But I start with it in words, just like it's you. You have the kidney disease. You're going to get treated, you're not going to get treated. So I know in the interests of time, I'm not taking you through all of that, but what I did want to show you is what I feel is some of the best payoff for this, which is that you can then take these models and use them to look at a moral hazard or a cost containment, cost growth perspective. So now I have my two possible treatment choices, and I apologize for using this one. I do tell them that the dialysis and transplant is really reversed in reality, but this one was easy for people to understand. So now I'm like, well, there's a choice of treatments. There isn't just one possible choice. There's a better, more expensive, and a cheaper, less effective treatment. And we want to think about choosing between the plans. So what we want to think about is the incremental AFP. So when you're sitting there not knowing, right? So chances are you're going to be in good health. You might get a heart attack. There's only 1% chance you're going to get kidney disease. Probably won't happen. Given that, how much are you willing to spend on insurance so that if you got kidney disease, you would have your transplant covered? So again, we have the incremental expected cost, the incremental increase in the AFP, and I stress, what's the real world opportunity cost? What are you losing in terms of housing and vacation and education for that? Then we talk about the incremental expected benefits. I will teach them how to do that in a sort of more traditional decision theoretic kind of perspective, but also just in everyday words. Okay, so I have a 1% chance of getting kidney disease. If I get the kidney disease, this plan will help me get a transplant and that plan won't. And even though it's very artificial, I ask them, what would you choose? So the latter parts are a bit quick, but you guys can see the kinds of models. And elsewhere in the course, yes, so sorry, I've covered those questions. So, understanding these issues definitely requires the students to be analytical and to be quantitative, but it really, you need no prior specific training at all. And I think that this really gives, you know, I didn't write down death spirals, which we hear about all the time, but these kinds of things gives people, the students, to think about death spirals. It gives them the tools to think about the 3 reasons high deductible plans cost less, you know, just the mechanics, the moral hazard, disincentive to care, and the selection effects. It gives them a wide variety of tools. It gives them tools to understand cost growth over time and so on. You can do both. I like the toy models with a wide variety of simplifying assumptions so that they actually have to calculate things. But then we also can speak analytically about general terms, and you can teach a wide variety of concepts and tools to a wide variety of students. So thank you very much.
Thank you, Dahlia. Any questions?
Okay. I can take them afterwards. Thank you. And I'll try and do the same courtesy Jeff did and put up Jennifer's talk.
I have one question here.
Oh, sorry.
I guess it's not being directed just at you, but it's more of a point that we might want to discuss. It's just, I'm just wondering about when we teach health economic tools, like the one that you described very helpfully, is that how comfortable do we feel as health economists as a discipline that we're exposing students to health economics applied tools, but not necessarily teach them the theory behind those tools. So it's just frequently we've been hearing, and it's very important that things are accessible and students digest what they're doing, but I guess there's a tension when we oversimplify what we're doing, because it's important for them to understand the theory embedded behind the content.
So I certainly emphasize when I do these things that there are enormous amount of simplifying assumptions, and I talk about how they're wrong. And I ask the students to try and say, in what way do you think this is unrealistic? So, you know, the one period insurance model, we spend a lot of time later on persistence, and that uncertainty unfolds over time. So I think it's really important, and I don't teach introductory micro anymore, but when I did the same thing there. I mean, the consumer surplus is a disaster of unrealistic expectations. And I agree it's important, so, but I think if we want them to think analytically, we also have to teach them to simplify, but I agree that they need to look critically at those assumptions. I completely agree with you. Yeah.
I was just curious how, and I think what I was looking for is how, I don't know if this is a 16-week semester or 8-week, how you spread this concept over the course, because you're saying it's a central thing for the whole course. So just curious to see if you had like a table of content for your weekly, and
right,
how you spread that concept over
so
the whole semester.
I would say that the value of insurance, selection, moral hazard with those kinds of models, I teach over 5 weeks with a once-a-week 3-hour course. But I do have in them both institutional issues, so we're talking about some of the real world institutions, we're talking about some of the ways in which the assumptions are wrong, so it's a little more than a third of my course. And then when we teach, you know, when I'm teaching cost containment and I'm teaching high deductible plans, we're again coming back to these.
Quickly before Jennifer starts, we have been passing around the questionnaire. If you already have one, don't do another one.